Chapter 13, Pharmacy Billing and Inventory Management. We have our objectives, things that you should learn throughout the chapter. Then we have our terms and definitions in the beginning of the chapter, as always. Definitely something that you want to study. We will go over them throughout the chapter. You can see there's quite a few. Everyone working in the pharmacy is responsible for maintaining the inventory stock. This is an essential part of our daily task as a pharmacy technician or in the pharmacy as a staff member. As stock is depleted, it is important to replace inventory. Although many different systems are available for ordering stock, the task of ordering may be delegated to a specific person in the pharmacy. It is then the responsibility of the staff to inform the inventory control person of decreasing stock levels. One method of replenishing the stock is just in time ordering. This is an inventory strategy in which medications are ordered and received only as they are used. A formulary is analogous to a backbone. The formulary is a list that describes all the medications covered under a specific insurance plan approved for use in an institution such as a hospital. It may also offer alternative medications if the first choice is not covered. For medications to become part of the formulary, they must meet certain requirements such as effectiveness and cost. These are determined by pharmacists, pharmacy technicians, physicians, nurses, and administrators who are members of the Pharmacy and Therapeutics Committee, the P&T Committee. Formularies are not the same at all institutional pharmacies or for all health plans. An institution can have an open formulary, which means any drug can be ordered and stocked for patient use. A closed formulary places certain restrictions on the drugs ordered. So most of the time in hospitals, you're going to see a closed pharmacy or a closed formulary. And that is just because it is a cost saving tool. And if the patient, hospital that I worked at, if the patient needed a medication that we didn't stock, we'd ask them for someone to bring it from home, or we made special considerations. But for the most part, it was a closed formulary. Often retail pharmacies stock a variety of medications to accommodate both their patients and the many different insurance companies for which they are contracted providers for. Each insurance company has their own formulary with recommendations for therapeutic alternatives when a drug is not covered under a particular plan. A therapeutic alternative is a drug that may differ chemically from the one prescribed but provides the same effect when administered to the patient. Hospital or home healthcare pharmacy is more likely to have a close formulary or a specific list of drugs to be kept on hand and dispensed to the patients and health plans served by the pharmacy. Drug utilization evaluation, DUE, formerly known as Drug Utilization Review, DUR, is an important process in ensuring that the correct drug is prescribed for a condition. When technicians are inputting prescriptions, DUE alerts interrupt the process if a drug interaction or duplicate therapy is found. Technicians must never override these warnings on the computer. Many formulary drugs are generic versions of proprietary brand name products. These drugs are as effective as the brand name drugs. They meet the same bioequivalence requirements but are less expensive. A health plan or prescription plan committee composed of pharmacists, physicians, and other healthcare administrators reviews drugs that have been approved by the FDA to ensure that they are cost effective. In addition, consideration may be given to drug companies that bid or give rebates when their drug is chosen for a formulary. This decrease in price to the pharmacy ultimately saves money for both the insurance company and the patient. Although most insurance companies cover most of the cost of a generic drug, some do allow the patient to choose the brand name drug. However, if the patient selects the brand name drug, he or she is responsible for the amount due based on calculation of the copay as outlined in the third party agreement. For example, if the normal copay is $5 per prescription and the patient chooses a brand name that costs $10 more than the generic equivalent, the patient must pay $15. The dollar amount of a prescription also depends on orders such as dispense as written drugs that require specialty codes. The three DAW codes that are most often used in the pharmacy setting are 0, 1, and 2. DAW 0 indicates that the physician authorizes a therapeutic alternative and the pharmacy can dispense the generic drug to the patient. DAW 1 indicates DAW dispense as written and is usually used by the physician to indicate that the trade or brand name is in some way medically necessary for the successful treatment of the patient. Often patients must have proof that other therapies have been tried but failed. Sometimes, such in the case of the drug as Celebrex, a patient must be 50 or older. Physicians must write either brand name medically necessary or dispenses written in their own handwriting. PAW2 indicates that the physician has approved the generic substitution of the medication prescribed. However, the patient has insisted on receiving the brand name medication. The terms trade brand and proprietary are used interchangeably to refer to the name of a drug product that was first patented and marketed by the owner or manufacturer. After a certain time passes, the patent expires. Eventually, other drug companies can apply for the right to produce the same drug product, although not all drugs will be available in generic form. For example, it is not usually advantageous to drug companies to make generic medications that are used by a small percentage of the population. Brand name drugs that are produced by non-proprietary companies as an alternative to the proprietary product are considered generic. Brand name drugs are usually protected for 17 to 20 years, depending on the drug company's petition to the FDA, before the patents expire. After the generic is introduced, prices can drop between 50 to 80%. And additionally, brand name companies can apply for up to 5 years of additional patent protection for the new medications they developed or for a new indication of a medication to compensate for that time lost while their products were undergoing the FDA approval process. Many different types of medical insurance plans are available. Understanding the policies and procedures of these plans is challenging, especially because their guidelines change regularly. The types of medical insurance plans and cards currently in use include the following. So, a CHAMP VA card, a drug discount card, Medicaid card, medical insurance ID card, Medicare Advantage card, Medicare card, Medigap card, pharmacy benefits card has RX printed on it, prescription coupon card by the drug manufacturers to patients, TRICARE, and workers' compensation. A health maintenance organization has specific features that distinguish it from traditional insurance programs. An HMO is an effective method of controlling healthcare costs. Aetna, Anthem, United Healthcare, and Kaiser are just a few examples of the many insurance companies that offer HMO coverage. So usually with an HMO, you have to use your primary care physician for everything. If you need to see a specialist, usually they have to forward that request out and things like that. Adjudication is the process of claims over a computerized system. If the insurance claim is rejected, the pharmacy either must troubleshoot the issues or have the patient pay full price for the medication. It is then the responsibility of the patient to contact the insurance company to obtain reimbursement. HMOs may require prior authorizations or certain medications per their formulary guidelines. State regulations regarding the types of forms used to approve such medications may vary. The prescriber must justify the therapeutic basis for the prescribed medication. This prior authorization must be entered into the system before payment is approved. One example is Botox. Botox is used to treat muscular disorders, but can also be used cosmetically. If a patient's plan does not cover cosmetic services, but the drug is prescribed to treat a muscular disorder, a prior authorization would then be required. Technicians are crucial personnel in securing the prior authorization for the patient. They may call the physician's office and or the insurance companies to ensure that the patient's needs are met. There are opportunities to specialize and work specifically as a prior authorization technician. These technicians are considered experts in prior authorizations and provide customer service support to members, customers, and or providers. They take incoming requests for prior authorizations for both formulary and non-formulary medications, and requests can be received by fax or phone from provider's office and from pharmacists. So I did actually work as a prior authorization technician for a while in my earlier career, and it was a pretty interesting job. It was a lot different than working in retail or in the hospital. It was really relaxed and just a different atmosphere. There is a lot of time on the phone and a lot of time sitting. So if you're one of those people that, like me, who are used to standing all the time and sitting was kind of hard at first, um, that might be a challenge, but for the most part, it's a pretty relaxing job, not high stress like most pharmacy positions. A preferred provider organization provides healthcare for members at a discounted fee. The benefit is that the patient can choose a physician from the insurance plan list of contracted providers, or they can choose to consult any specialty physician without PCP referrals. There are no requirements to choose a specific PCP. Members of a PPO may have to meet a yearly deductible, the amount that the patient must pay before the insurance company pays. The insurance then pays a certain percentage of the medical expenses and medication bills if the patient's claims meet the criteria. This helps control the cost to the insurance company because the patient pays everything the insurance company doesn't pay. From the pharmacy perspective, the billing processes for an HMO and a PPO are similar. The difference is that if the patient has a PPO, he or she may have a deductible to meet before the cost share, such as percentage or copay, becomes active. Programs such as Medicaid and Medicare are examples of state managed and federally managed medical insurance plans. Each employee in the United States pays the government a percentage of his or her income toward Medicare. A percentage of each state budget is applied towards Medicaid. Each plan has specific guidelines that must be followed precisely for patients to qualify for reimbursement. Both plans were implemented in 1965. Medicaid provided health care services to low income children, the elderly, the blind, and people with disabilities. Until 1977, Medicaid was associated with the Social Security Administration. Later in 1986, coverage was expanded to infants of pregnant women with low incomes and became state regulated. In 1966, more than 19 million people enrolled in the newly formed Medicare program. Coverage consisted of several parts. In 1972, Medicare eligibility was extended to include people older than age 65, those younger than 65 with long term disabilities, and individuals suffering from end stage renal disease. So here's just a little more on the different types of coverage. A significant change was made in 2003 with the Medicare Modernization Act and the creation of prescription drug discount cards, which allow competition between health plans and benefiting participants. In 2006, Medicare Part D was enacted. This requires the federal government to provide subsidies to participants whose income is less than 150% of the federal poverty limit. Those with higher incomes would pay a greater share of drug costs as of 2007. Certain individuals may be covered under both Medicaid and Medicare and are known as dual eligible. In 2010, the Patient Protection and Affordable Care Act was signed into law and had a significant impact on Medicare and Medicaid services. Many savings programs assist low income participants with out of pocket costs. Each state has its own program for assistance and may or may not include services such as home delivered personal care and other community based services for disabled patients. Table 13.1 lists the chronological changes in Medicare and Medicaid coverage. This is kind of a nice little chart to see how it has evolved throughout the years. It's still evolving as we go. Medicare is a federally sponsored program for seniors, the disabled, and dialysis patients. It functions like an HMO and PPO. The patient must see a provider who accepts Medicare, but the patient has a yearly deductible and a percentage share of the cost. The share of the cost is similar to deductible and copay combined. The patient is responsible for paying a deductible up to a certain amount in a hospital setting. Medicare has four parts: Part A, B, C, and D. Part A is for hospital, Part B is for medical insurance, C is Medicare Advantage, D is prescription drug plan. So that is what we will be working with the most in pharmacy. Medicare services were expanded in 1980 with the creation of Medigap plan, which is also regulated by the federal government. The last significant update to Medigap plans was in June 2010 when Medicare Select was introduced in some states. This required participants to use specific hospitals and specific providers for full coverage. So traditional Medigap plan offers optional insurance policies that can be purchased through privately owned insurance companies. The plans are intended to fill the gap in the Medicare program coverage. However, if you have Medicare Part C, you cannot use or obtain Medigap. Pharmacies must apply for a National Provider Identifier, an MPI, from the CMS. All providers who bill electronically must have an MPI, which is required by HIPAA. Any pharmacist who provides services such as consultation and does not bill for this time under a pharmacy with an MPI must have his or her own NPI. The MPI pharmacy number may be assigned either per person or per pharmacy, depending on each state's law. And here's an example of a Medicare Part D card. Actually, this is not an example. This is a example of an A and B card. I don't know why it says that, but anyway. Here are box 13.3 of various supplies covered by Medicare. So blood glucose testing strips, heparin for home dialysis, hospital stays, insulin, lancets, Lasix, and nebulizing solutions. And Lasix is the medication, the generic furosemide. Medicaid is a federal assistance program based on income and other circumstances. Individuals earning below the national poverty level are eligible for health care services. Each state has its own Medicare program for low income residents. This also includes uninsured pregnant women and those with certain disabilities. Medicaid is funded by both the state and the federal government, depending on a state's level of unemployment and poverty. It may receive matching funds from the federal government. The following are the three major levels of coverage in the Medicaid system. The patient may not be responsible for any cost. Share of cost. The patient's plan requires that the patient pay a deductible. Or three, geographical managed care program. A geographical managed care plan allows patients to belong to a medical group with which Medicaid has a contractual agreement. Effective January 1st, 2014, Medicaid benefits were expanded to include individuals aged 19 to 65 with incomes up to 138% of the federal poverty level. For a single person, this translates into an annual income of $15,856. This change opened up Medicaid for many childless adults who were not previously eligible. So states must provide certain mandatory benefits for Medicaid participants. So all these things listed, and states can choose to provide optional benefits for Medicaid participants, such as these items here, like chiropractic services, dentures, eyeglasses. You must know whether the patient has Medicaid benefits. If the patient is covered under Medicaid, you need a copy of the patient's insurance card. This card identifies the program under which the patient is covered. Because different states authorize coverage at varying durations, it is important for the technician to verify eligibility each time the patient has a prescription filled. Many states use the electronic Medicaid eligibility verification system, which verifies coverage by electronic transmission or by telephone. TRICARE is a healthcare program for military personnel and their families. This includes approximately 9.6 million active duty service members, the National Guard and reserve members, and retirees. It is managed by the Defense Health Agency and covers beneficiaries in the Army, Navy, Marines, Air Force, and Coast Guard. Here's an example of their enrollment card, or they a lot of times will just have their military ID. The Civilian Health and Medical Program of the Department of Veteran Affairs, which is CHAMP VA, is a health benefits program in which the VA shares the cost of certain healthcare services with eligible participants. And here is an example of a CHAMP VA card. Workman's compensation is a type of insurance paid by employers to entirely cover injuries suffered by employees while on the job. Federal law requires employers with a certain number of employees to offer workman's compensation. Insur- Insurance coverage is provided by private insurance carriers. Anyone who works for a company that pays into workman's comp may be eligible to use this insurance if he or she has a work-related injury. The patient does not have to pay anything. Instead, claims are filed electronically or on hard copies to the insurance companies. If the patient arrives at the pharmacy with a workman's compensation claim, it is important to obtain billing information before dispensing medication if possible. This may involve contacting the patient's employer, obtaining the billing information over the phone from Human Resources Department, and then calling the Workmen's Compensation Insurance Company for further information. The term third party billing refers to the portion of payment reimbursed by insurance companies. The three entities that are responsible for payment include the patient, the pharmacy, and the insurance company. It is customary for the pharmacy to bill the insurance company on behalf of the patient. The patient is responsible for meeting the copay or deductible at the time the medication is dispensed, and the pharmacy must collect the rest of the drug costs from the insurance based on contracted rates and dispensing fees. A copay is predetermined amount the patient always pays when a medication is dispensed, whereas deductible is the amount out of pocket cost the patient must pay before his or her insurance coverage is activated. Table 13.2 lists minimum information required by insurance companies. So this is the information required to do a billing claim. Pharmacies that send claims electronically to an insurance company participate in point of sale billing. Electronic billing is performed by a secure data and transactional network to ensure patient confidentiality. The insurance company verifies eligibility, identifies covered drugs, prices a claim, and returns a response to submitting pharmacies within seconds during the prescription processing function, which we know as adjudication. Often, an insurance company pays for a medication only if a prior authorization is first received. Prior authorization is needed for a variety of reasons. For example, the drug of choice may not be included in the formulary of the insurance company. Two types of forms are used to receive these prior authorizations: a prior authorization form or an ETAR, which is an internet-based paperless process for submitting an electronic TAR for patients. And TAR is treatment authorization request. So here's an example of a form. The physician often must produce documentation explaining why a specific course of therapy is needed, such as the patient tried and failed other therapies and they were ineffective, and the patient has allergies to the certain medication that might be on the formulary. The patient must undergo diagnostic tests that require the requested therapy. All of this information must be provided by the physician because the pharmacy does not have access to the patient's records. The insurance company either approves or denies the authorization in 24 to 48 hours. Rarely does the insurance company or the physician alert the pharmacy when authorization has been approved. Therefore, we usually run in 48 to 72 hours again. Box 13.4 lists information included on a prescription card. So we should have an RX bin. It's used as an internet protocol address to direct the claim to the correct third party provider. All network pharmacy payers have an RX bin. You also need a pharmacy benefit processor control number, a PCN. Some, but not all, network pharmacy payers use this number labeled RxPCN for network pharmacy benefit routing, along with the RX bin. The prescription group number, the RX group, directs the claim to the specific insurance benefits of that group. The identification number, so unique for each specific member or family member group. Each member of the family has the same ID number. However, an individual code is used to differentiate family members from one another. Often the cardholder or the primary person on the insurance is person 00 or 01. The spouse or other insured adult is person 01 or 02, depending on the primary person is. And the coverage for children on the plan is listed in numerical order according to their birth order. So their numbers are firstborn 03, second 04, and so on and so forth. The date of birth must match what the insurance company has on file for a patient. And you would think, yeah, like that's obvious. However, after working in the pharmacy industry for many years, I realized that there are so many times where the insurance company has the wrong birthday. Super interesting. Something I never thought would still be a thing, but yeah, apparently it is. The sex code must match sex filed by the insurance company. It will reject claims for drugs if the sex code is incorrect. For instance, the technician submits a claim stating that Mary is a man and attempts to bill for insurance for orthotricycline. Um, it would be rejected because males are not prescribed birth control. Each pharmacy has its own specific computer system which details each patient profile. Basic information includes the following: name, date of birth, address, phone number, sex, allergies, both food and drug, insurance providers, information, and over the counter drugs, diagnosis or disease states. If any of the information is a mistake, the insurance claim may be rejected. If the patient does not have insurance, he or she must pay the full price of prescription. The cost of a prescription can vary greatly. Many pharmacies offer certain generics at a lower cost, $4 for 30-day or 10 for 90-day, and the use of generic drugs can reduce the medication costs greatly. If the patient has insurance, determining the guidelines of the program is of primary importance if the pharmacy is to receive reimbursement. Process by which all claims are processed over a computerized system is referred to as adjudication. The insurance determines the amount of coverage per medication based on various criteria, such as the following: average wholesale price, AWP, can be found in Drug Topics Red Book, or this information may be contained in a portion of the pharmacy database. Use the Red Book to determine the price of a medication based on the listed price. The Red Book is available electronically, and the online database supplies real-time updates to medication price changes. Copays, a relatively small fixed fee required by the health insurer to be paid by the patient at the time of each visit, outpatient service, or with a prescription. When handling a patient's medication claim, the pharmacy technician may be responsible for using the insurance company claim form to relay the necessary patient information. Because each company requires its forms to be filled out entirely and correctly, the technician must know the specific needs of the company. Universal claim forms are used in certain circumstances. Here's an example of a universal claim form. Here are the general types of information that are required for that. A prescription may not be covered for the insured patient for many reasons. For example, the NDC may not be covered. The NDC number is organized into three sections: the labeler code, the product code, and the package code. All medications have an NDC number. So even your medications that are over the counter at home, you know, look at them. Ibuprofen, your Tylenol, your, whatever you have, you should look at it because it does have an NDC number at the top. Other common reasons why a prescription may not be covered: Coverage has expired, limits have been exceeded, patient is trying to refill too early, the cardholder's information does not match, the physician who wrote the prescription is not the patient's PCP, prescription is written for an invalid amount of medications. Most insurance companies cover only a 30-day supply, unless it is a mail order, which covers a 90-day supply. If the patient has lost his or her coverage, the claim is rejected. Following HIPAA regulations, the pharmacy does not have access to information about the reason for rejection, and only a termination date is disclosed. Patients often are unaware of why coverage has been discontinued and may want the pharmacy to investigate. Pharmacy personnel are not permitted to call the insurance carrier about these types of inquiries. So, yeah, the patient will definitely want you to call. Even if you did try to call, they would not give you any information. The phrase limitation of plan exceeded refers to a patient who has exhausted his or her pharmacy benefits for the specified time period or quantity limitation on a drug. If a prescription requests a greater amount of the drug that is allowed by the insurance plan, the plan limits are exceeded. For example, some government insurance plans limit the number of prescriptions that can be filled per month or per year. If the prescription is written for a specific quantity of medication that exceeds the maximum amount to be filled per day, the prescription is rejected and the patient must contact the insurance company for special permission to obtain the drug. Limit exceeded could also mean that the patient has met a yearly or lifetime benefit amount. Some patients are exempt from these types of limitations because of their illness. This includes individuals who have diabetes and those who have been diagnosed with human immunodeficiency virus, HIV, infection, or acquired immunodeficiency syndrome, AIDS. People with diabetes mellitus require a continuous refill of lancets and blood testing strips to monitor their blood glucose level. In addition, they must refill their insulin syringes monthly. In the case of patients treated for HIV or AIDS, the medication is expensive, and these patients usually have to take many medications simultaneously. When a claim is rejected because the maximum limits of the insurance are exceeded, the technician must explain the problem to the patient. The patient is ultimately responsible for contacting the insurance company to dispute the problem. Formularies tend to be specific. This includes the decision on which drugs are included in the member's plan. These drugs are identified by their NDC, a code assigned to every drug in the United States. If the code submitted is not in the formulary, the claim is rejected by the insurance company. In this case, two options can be explored. First, the pharmacist can contact the physician and request that the prescription be changed to a drug that is covered under the patient's insurance plan. Second, the physician can submit a prior authorization form to the insurance company indicating why the patient must take the non-formulary drug. The type of prior authorization form varies depending on insurance company guidelines. Physicians normally complete and submit the prior authorization form for approval. This process can take up to 2 weeks. Therefore, the patient can either purchase the medication for immediate use or wait to have the prescription filled after approval or rejection is given by the insurance company. If the patient pays up front and the medication is approved, the patient is reimbursed by the insurance company after the pharmacist completes a reimbursement form for the patient. Patients attempt to have their prescriptions refilled for several reasons when they have medication remaining. Most of the time, it is not a problem to obtain a refill 1 week before the prescription's refill date. However, there are instances in which the patient may request a refill as early as 1 week after having the prescription filled. For example, the patient may be leaving the country for an extended time and wants to ensure sufficient medication is available until he or she returns. Most insurance plans allow early refills in circumstances such as vacations or the occurrence of devastating effects. If the patient's insurance will not pay, the patient is responsible for the cost of the medication. Prescriptions normally are written for 30, 60, or 90-day supplies, depending on the condition treated. Mail order companies usually fill up to 90-day supplies for certain maintenance drugs, such as diabetes or heart medications. Sometimes the amount of medication prescribed is limited because of safety or legal issues regarding the dispensing of a specific medication. Because certain medications are dangerous, they may not be prescribed for more than 30 days. Examples include U.S. Drug Enforcement Administration Schedule II controlled substances and a specific drug, isotretinoin, and acne medication, which has been linked to teratogenicity if given to pregnant women. Many insurance plans allow additional savings if refills are ordered by mail order pharmacies that are on their list of participating pharmacies. Probably one of the most common problems arises when the cardholder's information does not match the processor's information, resulting in a claim rejection. To determine whether this is the case, we should always recheck the information submitted to the insurance company, like the health plan card number, the identification number and insurance number, the patient's name, date of birth, and relationship to the insured person. Sometimes an insurance company mistakenly rejects a valid claim. When this happens, the pharmacy technician can resubmit the claim. Special attention should be paid to the rejection codes provided by the payer in the remittance information. Next, the insurance company determines whether the issue has been resolved and the claim can be processed and paid. It is the responsibility of the pharmacy to keep records of claims that are submitted until they are processed or denied. Follow up is the key to ensuring that payment is received. Often, insurance carriers enact plan limitations to control drug use and to reduce drug costs. Some examples can be maximum amount of medication that can be dispensed at one time, day supply restrictions, refill limits, requiring prior authorizations for certain medications, and step therapy. One or more cheaper medications must be demonstrated to be ineffective before more expensive medications may be used. Some patients do not have insurance coverage and are solely responsible for their prescription costs. These patients can pay with cash, check, or credit or debit card. Patients can obtain drug discount cards from a variety of sources. These do not offer insurance benefits, but instead allow the patient to obtain medications at the contracted provider rate. And you'll see these a lot of times, the patients will have them. And you'll see them at random places where they're just giving them out. With a private plan, the patient obtains a prescription drug card from a pharmacy benefits manager. U- Usually, these plans are very expensive. Health savings accounts and flexible spending accounts are something like a savings account that can be used to pay medical bills before a deductible has been met, along with copays for prescriptions and office visits. The government has put limits on the amounts that can be put into these accounts per calendar year. There's also a use it or lose it component. Some employers contribute to these accounts and some do not. Restrictions are placed on what is covered. Participants must be knowledgeable about the regulations affecting these types of accounts. Many times, pharmacists must explain the various types of benefits to patients. Technicians play an important role in helping patients understand their coverage. Proper inventory management is the key to an efficiently run pharmacy. Having the needed medications and supplies on hand to serve the patient's needs is a top priority. Minimizing the carrying costs of the pharmacy's inventory investment enhances the pharmacy's ability to earn a profit. Inventory management focuses on ordering stock, proper storage of medication and supplies, repackaging, disposal of used and unused pharmaceutical products, and distribution systems. Everyone in the pharmacy is responsible for maintaining the inventory stock is essential part of our daily tasks as a pharmacy technician or just in the pharmacy in general. As stocks are depleted, it's important to order replacement inventories. Each pharmacy orders drugs that include formulary drugs and a limited amount of non formulary or less commonly used drugs. The established level of medication stock kept on hand any given time is referred to as the periodic automatic replenishment level. This is the minimum amount of medication that should be maintained in the pharmacy at any given time. Most hospitals have a technician who is in charge of maintaining stock levels and completing the special ordering of medications. The technician who orders the stock is responsible for the actual ordering, billing, and restocking of the pharmacy shelves. However, it takes a group effort in the pharmacy to maintain stock levels and avoid having to borrow items from other hospitals or special order them at a higher cost. Every day, the pharmacy depletes some of its stocks of drug and supplies. Although we have different systems of ordering the medication, most orders are normally placed on a computer. Depending on the location of the warehouse or manufacturer, the turnaround time for the shipment may vary. It's usually less than 24 hours, so like the next day, there's like a cutoff time every day. And when the shipment arrives, we will check the shipment against the inventory lists in initialing where we received everything. Placing stock on the shelves is another important duty of the pharmacy technician. It is the point at which the stock is rotated. Placing medications with later expiration dates farthest back on the shelf ensures that the medications with the earliest expiration dates are used first. The inventory technician is also responsible for returning damaged items and expired agents and handling recall items according to the manufacturer's guidelines. Maintaining a par level in the pharmacy is important for several reasons. Many manufacturers do not fill orders on weekends or holidays. Thus, if the pharmacy depletes its stock during this time, it may have to wait until the following delivery day to receive the necessary stock. It is serious if a patient cannot obtain an essential medication because the pharmacy is out of stock. Patients visiting a community pharmacy may be able to go elsewhere to have prescriptions filled, but hospitalized patients rely on the hospital pharmacy to stock medications. If stock will not arrive until the following Monday or Tuesday, the only recourse is to use an express delivery company contracted by the pharmacy or to borrow the medication from another pharmacy. When a pharmacy does not carry a medication, perhaps it is new or uncommon and may be ordered from a drug wholesaler. It's important to know the length of time needed for the wholesaler to deliver a medication and to follow the order's progress. Special order prescriptions should be filled in a specific location in the pharmacy. The technician must check for special orders each time the stock arrives. This ensures that the patient is not waiting for a medication that was received by the pharmacy a week ago. In addition, if medication has not been delivered by the expected date, the wholesaler should be contacted to determine whether there is a back order, ordering problem, or other issue. Notification of any ordering issues as soon as possible means the patients will not have therapy delayed any longer than necessary. Most manufacturers identify their products with barcodes that can be scanned. This process accelerates the input of information because one pass of the barcode device identifies the drug strength, dosage form, quantity, cost, package size, and other information necessary to fill the medication or device. Automated dispensing systems involve technology designed to reduce labor and increase patient safety. They store medications and control electronic dispensing. They are used in community pharmacies to monitor the inventory as tablets and capsules are dispensed into a drug vial from a bulk bin. As the pills pass the beam of light, they automatically are removed from the inventory. And here is a picture of a technician using a handheld scanner on the OmniRx. So this is one of the ADAs that hospital units use to monitor controlled substance and inventory. Although manually ordering is being eliminated slowly as the primary ordering technique, it is still important in the continued monitoring of stock levels. Some pharmacies still visually note that the stock is getting low or use ordering cards that stay inside the medication box. These cards list the drug information, including the ordering number and the necessary par levels. And one thing is the inventory is on a computer system, so things can happen. The numbers can get changed on accident by somebody, things of that nature. So if we go to fill a common medication and we didn't get an alert that it was out of stock, depending on your pharmacy's computer system, you go there to the shelf and there's no medication. This is a common medication. You can probably guarantee that the inventory is off in the computer, and that's why more isn't on the shelf because it thinks we still have some. Just-in-time ordering allows for just enough stock to be ordered to avoid excess inventory sitting on shelves. For example, when one bottle is used up, just a single bottle is ordered just in time to replace it. More commonly, orders are processed electronically by the computer or handheld computers that transmit the order. The following list categorizes the drugs stocked by many pharmacies. Formulary and a hospital pharmacy, these drugs normally stocked by the pharmacy are approved by the P&T committee. In a refill pharmacy, a specific formulary indicates which drugs are on the approved list by the patient's insurance company. Fast mover, these drugs typically are kept in a separate area from the normal stock because of the high volume of use. Slow movers, these drugs are prescribed regularly by a few physicians but are not commonly prescribed. They must be checked before ordering and periodically to ensure that the drugs are not close to expiring. Special orders, these are drugs typically used by only a few patients, but they may be important for proper treatment. It's easy to forget to order these drugs because of their infrequent use. The time of year, the drugs that are part of this category vary depending on the time of year. Many medications that are fast movers during a particular time of year may need their par levels also raised during that time period. For an example, albuterol inhalers are normally fast movers in the spring when allergy symptoms and consequently asthma or respiratory tract systems increase. Antiviral medications used to treat influenza are prescribed more often during the flu season from fall to spring. And all pharmacy staff must be aware of the types of medication used during different times of the year and understand how levels fluctuate. New stock. So, stock normally arrives daily at the pharmacy from different sources. For billing purposes, it is important that all stock be checked completely against the packing list when first received. Procedure 13.1 presents a step by step approach that should be used when receiving stock. And you will do this in your science interactive lab, or you may have already done it. As stock arrives, it is important to follow the manufacturer's requirements for storage. Certain medications must be frozen at temperatures between -20 degrees Celsius and -10 degrees Celsius, refrigerated at temperatures between 2 degrees Celsius and 8 degrees Celsius, or stored at room temperature, which is 23 degrees Celsius. Light or humidity can also affect the stability of the medication. Therefore, care must be taken to protect stock from either light sources or excessive humidity. If these guidelines are not followed, the medication is compromised, rendering it unusable. Medication is returned to the warehouse or manufacturer for four main reasons: drug recalls, damaged stock, expired stock, and the medication is about to expire. So for drug recalls, there's three different classes. The recall one is for drugs that may pose a serious threat to users, like death. Two is recalls for drugs that may cause a temporary health problem. And three are recalls for drugs that violate the regulations concerning container defects or have a strange taste or color. Manufacturers are required by law to recall any product that has been found to violate any of the following guidelines. Labeling is incorrect, product was not packaged or produced properly, drug batch was contaminated. The FDA has required removal of the drug from the market as a result of safety risk. Any other change occurs that causes the drug to fall outside of the FDA or manufacturer's guidelines. Here's a sample recall notification. If you notice that some drugs are damaged en route to the pharmacy, but you are not aware of damage at the time of delivery, it is not too late to return the damaged stock to the manufacturer. It may be necessary to first contact the manufacturer and obtain an authorization before damaged goods are returned. Patient may also notice damaged stock. Sometimes EpiPen or Imitrex injections have bent needles, broken plungers, or other issues. In these cases, the patient returns the medication and the pharmacy replaces the item. The pharmacy must then contact the manufacturer who sends a replacement to the pharmacy directly and may or may not collect the damaged merchandise. Some pharmacies have a policy to pull any medication that expires in 3 months or sooner. This ensures that no drugs on the shelves are close to their expiration date. Depending on the contract between the pharmacy and the manufacturer, it may be acceptable to return items as long as they can be bundled into a minimum package size rather than as partials. For instance, if the stock of cimetidine expires within 3 months, the manufacturer may allow it to be returned for full or partial credit if a box of 100 tablets can be returned at one time. Following manufacturers' guidelines for returns is important. Hazardous chemicals, including cytotoxic agents, must be repackaged carefully to avoid breakage during transport. Pharmacy personnel can also pull and return slow moving stock that has 9 to 12 months before expiration. Some companies' sole job is to process returns for hospitals, wholesalers, pharmacy chain stores, and independent retailers. They are responsible for all records and recalled items and for disposal of the hazardous waste. Many items cannot be returned to manufacturers. Some examples of non returnable drugs are any drug that is reconstituted or compounded in the pharmacy, partially used bottles of medication, and any drugs that have been repackaged by the pharmacy. These drugs, including most reconstituted agents, can be discarded in the pharmacy trash. There are special storage and disposal considerations from the EPS based on environmental hazards. The Environmental Protection Agency has a P listing that includes specific drugs that must be discarded in special containers. Toxic agents such as chemotherapy waste must be discarded in a yellow sharps container. Drugs such as nitroglycerin must be put into a black container along with neostigmine, warfarin, and phentermine. Purple is used for live vaccines or hazardous waste, and non-hazardous intravenous agent should be discarded in a standard blue and white sharps container marked for proper disposal. Controlled substances must be counted and co-signed by a pharmacist before they are destroyed. Before any scheduled medications are destroyed, the DEA must be contacted for specific instructions regarding their destruction. A pharmacist always must be present to co-sign for the disposal of controlled substances and must return required information about the disposal to the DEA. The DEA issues a receipt for Schedule II merchandise that is destroyed. This receipt must be kept for 2 years from the date of receipt or disposal with the Schedule II inventory. In addition to regular pharmacy inventory returns, technicians must routinely check patient medication bins ready for pickup that have not been picked up by or for the patient. They may not be picked up because of unknown changes in medication, hospitalizations, or costs. Those that were charged to insurance must be reversed to the third party by electronic submission to credit the patient and remove the prescription from the insurance. Once the completed prescriptions are removed, names and other pertinent information are blacked out and labels are placed in a HIPAA trash container. Medications that have never left the pharmacy may then be returned to stock bottles. So you will usually do this pretty much every day at your pharmacy. When ordering stock for the pharmacy, the technician orders from a centralized warehouse the pharmacy owns, from a wholesaler, or directly from the manufacturer. Medication, devices, and pharmacy supplies are available from various sources. Prime vendors are large distributors of various medications and retail products to pharmacies. Wholesalers are companies that stock a variety of drug manufacturers' medications and normally have a just-in-time turnaround for order drugs. Direct manufacturer ordering must be used under certain circumstances. For example, a group of pharmacies may join a group purchasing organization that contracts with the manufacturer for better pricing. Contract is usually based on the quantity ordered and includes specific return policies and conditions. And here's the difference from ordering from manufacturers, wholesalers, and warehouse repackaging plants. So you can kind of see the difference there. Special considerations apply to a host of drugs ordered by pharmacy, such as controlled substances, investigational drugs, cytotoxic drugs, and hazardous substances. Each of these types of medications requires special ordering, inventory, storage, handling, and return documentation. The DEA requires special forms to be completed for ordering, transferring, and returning Schedule II substances. Investigational drugs typically have documentation that must be completed and returned to the manufacturer each time a medication is dispensed. These drugs are stored and inventoried separately. Cytotoxic drugs do not need special documentation, but they should be handled with great care and placed in a safety cabinet according to the manufacturer's guidelines. Certain cytotoxic agents must be refrigerated and should be clearly marked to separate them from other agents. Most pharmacies stock certain chemicals that are considered hazardous. You must know where the SDS safety data sheets of your pharmacy are located in case of a spill. Agents such as phenol should be stored behind cabinet doors to protect individuals from accidentally knocking the bottle off of a shelf and inhaling the toxic fumes or coming in contact with the agent. Although many of the guidelines can be found in each pharmacy's policies and procedures manual, it is the responsibility of the pharmacy technician to be aware of these guidelines and of federal and state regulations. This requires continuous effort to ensure that the regulations that apply to your pharmacy are updated to reflect the current requirements. Patients rely on the knowledge of the pharmacy technician, which is why competencies in the area of billing and inventory are extremely important in the daily functions of the pharmacy. All right. Do you remember these key points?